the incidence of kids showing up with hyperglycemia has gone up quite a bit, which is those two things are separating. There's so many valid reasons for that happening, some of which are good, some of which are not good. And I can't tell because the way that right now, the way we use EHRs, that narrative is hard to discern. Each one of you, as physicians, said it could be this and could be this. And at each time we were like, yep, it could be. Okay. It could be that kids with DKA are not going into the practices. They're going straight to the ER. And it could be that the practices are getting a little bit better at identifying hyperglycemia earlier. So it's showing up in the diagnoses. It could also just be that more kids are getting T1D, which we have evidence to support. And so that's why we're seeing more hyperglycemia. It could be a couple things. And in order to figure this out, when you take all the kids in Dan's network and you take all the kids in PCC's network, there's enough data there that we should be able to understand stuff, but we need the doctors, like George was saying, we need the doctors to click the right boxes so we can connect the dots.
Correct.
So the first thing that you guys could do together would be to try to get the number of type 1 diabetes in both of your registries.
That's right.
Yeah.
It's identifying the current population within both EHRs. How many kids do we have with type 1 diabetes? How many siblings do they have? How many siblings do they have of a particular age if we decide that we want to screen kids? And we'll talk about screening here in a minute. And I would also add that we have to think about other diseases that are related to that. And so we have to not only look, in this case, at kids with type 1 diabetes, but how many siblings have celiac disease? Or how many kids have celiac disease? And are those kids that a clinician should consider with certain histories and certain situations? Do I want to screen the other siblings for not only autoantibodies for celiac disease, but really think about type 1 diabetes? And it's that ability of using a pediatric EHR, which is thinking broader than just type 1 diabetes, but the connection with celiac disease. So you're right, Herb. We want to identify the populations, and the specific related diseases and conditions. I'm really excited about the capabilities to do that.
Yep.
So that first step seems to be pretty simple from a mechanics point of view, right? You just run a query. We don't know the quality of the data, right? Somebody forgets to put somebody could say syncope as the initial diagnosis for a type 1D at presentation with DKA because they passed out and sent it to the ER. But we would get a general idea of how many kids. And I'm guessing it's going to be something every year around, I think it was 2 to 4,000 kids in all of your network, all of your data sets that have stage 3 type 1D. Now, a little more complicated, which is what we were talking about earlier before we started taping the show, is how many of those children presenting with type 1 diabetes are in DK? And that gets a little more complicated because most pediatricians don't measure pH off the blood. We're not blood gas machines in the office, so we don't really know who is acidotic, who's not at the time of presentation. And the way a lot of these data exchanges work, and please correct me, I'm not in the EHR space, but if they go in the PICU and the PICU puts the DKA as a secondary diagnosis, that may not be showing on any of my billing charges going out of my office EHR because I'm not billing for that DKA episode in the ICU.
And you make a good point, Herb, because it might come back from the children's hospital or the local hospital with a diagnosis of DKA. Fortunately, with care quality now, we're getting much, much better data and more relevant and more accurate data. The question becomes then, does the clinician understand the importance of documenting things like DKA? And it's what George suggested just a few minutes ago. It's a little bit of a garbage in, garbage out situation, and we have to rely. The EHR cannot think about what it should be it's going to rely on the clinicians to document properly.
Because
Yeah.
I don't like ECW, and I say it over and over again. For the life of me, I wish I had or PCC in these clinics that I help. But in the process in ECW is if Fairfax Children's Hospital sends it electronically, right? There's this one bucket that you click on it and it says all the diagnoses. Then you click on it, then it carries it over to the problem list. Then you got to click on it again to put it on your assessment of the patient, right? And if you don't know that it's back there and the data enters changed, hidden on the right side of the screen, you're never going to see it.